Hello and welcome to Autism Specialty Care Education Series, which has been brought to you by India Autism Center and NeurAbilities Healthcare. Through this webinar series, we hope to cover a wide range of topics and provide comprehensive evidence-based information to assist educators and families in developing effective educational programming for their children and students with ASD. I'm Sakhi Singhi, Project Coordinator at India Autism Center, a first of its kind integrative community project coming up in Bengal. You can know more about it by clicking on the links in the chat box or following our social media pages. I'll also be attaching India Autism Center's brochure for your perusal. We also have here with us Sandra Bean Lewis, Director of Marketing and Community Affairs at NeurAbilities Healthcare, which brings together the experts needed to provide evaluation, diagnosis, and treatment for individuals across the lifespan with neurological, behavioral, developmental, and cognitive concerns. This webinar series highlights many of the specialty care services of NeurAbilities and the experts who work together to bring patients of all ages personalized care. Today's webinar is by Dr. Azlen Theobald. Dr. Azlen Theobald is completing a post-doctoral fellowship in clinical neuropsychology. Her areas of expertise and specialization include ADHD, Autism Spectrum Disorder, Tourette syndrome, traumatic brain injury, and dementia. She completed her master's and doctoral degrees in clinical psychology at LaSalle University in Philadelphia, with a concentration in child and family psychology. Dr. Theobald's current research focuses on improving social outcomes for children with neurodevelopmental disorders. Dr. Azlen will be talking on improving social outcomes for children with autism spectrum disorder and other neurodevelopmental disorders. We'll begin today's webinar in just a moment, but know that we'll be fielding questions today at the end of the session. However, you can ask them anytime by clicking on the chat box below. When you click on the chat box, address your questions to the moderator, and we hope to have your questions answered towards the end of the session. If you have any general questions about IAC or NeurAbilities, you can address them in the chat box below. There is an e-certificate of attendance for this webinar, and we'll be sharing the Google link before the question and answer session. It is mandatory that you fill the link within 24 hours. Questions about e-certificates are taken on email or WhatsApp, and the contact information will be shared on the slides after the webinar is over. According to our latest webinar policies, participant video will be permanently stopped if it appears to be unclear or distracting, and we'll be locking the meeting in the next 10 minutes. Thank you all for joining us here today, and I'd like to welcome Dr. Azlen.
Good morning. Thank you so much for that warm welcome. And thank you to our attendees for taking time out of your busy days, both in various time zones, to attend this webinar. I'm so excited you're here and to talk about this topic. It's very important to me. And I'd like to thank the India Autism Center for hosting this webinar. I'm going to share my screen with all of you, so you should be able to see, let's see what I am seeing. So what we're going to talk today is about improving social outcomes for children with autism and other neurodevelopmental disorders. I will get into what that means, but it's typically disorders that have that are chronic, that have lifelong patterns. So things like not only autism spectrum disorder that begins in the early developmental stage, but also Tourette syndrome and attention deficit hyperactivity disorder, or ADHD. I'd like to thank the India Autism Center for hosting this webinar and their wonderful support of this topic. Being a child or adolescent with a neurodevelopmental disability is incredibly challenging. It really has long-term impacts on their socio-emotional development. So we're going to talk today about strategies that can help them feel more comfortable. Much of what we'll talk about is particularly in the classroom, that will help them feel more comfortable, more accepted, and hopefully improve their social outcomes. So some of the objectives for today. First, we're going to outline the criteria for an autism spectrum diagnosis and additional developmental disorders, as I mentioned earlier, such as Tourette's syndrome and ADHD. Next, we'll talk about the influence of stigma and rejection among children who are of different neurodevelopmental presentations. We'll discuss ways children perceive others from different stages of development and interventions that have been studied to date to help improve peer acceptance. And lastly, we'll discuss interventions that I and others have more recently considered to help improve peer acceptance, and how parents, teachers, and caregivers can help bridge the gap between peers to help our children feel more safe, more comfortable, and ultimately enhance their self-esteem, their self-view, and their resilience. So first off, let's just review the DSM-5 criteria for autism spectrum disorder, Tourette syndrome, and ADHD. Many of you may be well familiar with these criteria already, but I will go through them briefly. So autism spectrum disorder, also ASD, as many of you know, the previous terminology that kind of differentiated something called Asperger's syndrome and autism spectrum disorder were two different diagnoses in the DSM-4. With DSM-5, that Asperger's syndrome diagnosis has gone away. It has been eliminated. It's still in the nomenclature, you know, in a number of different settings. In the media, it's still somewhat prevalent, at least in the United States to a degree, but it is no longer a diagnostic nomenclature that's used. So it's really just this autism spectrum disorder, and many, you know, neurodevelopmental and mental health disorders are viewed on this spectrum. I tend to view them that way, and I find it helpful to talk about them, even, you know, ADHD, Tourette syndrome, as a spectrum. So just because a child ticks off all the boxes of a diagnosis, there's still a lot of variability within that diagnosis, as we all know. So ASD DSM-5 criteria, it's persistent deficits in social communication and social interaction across multiple contexts. So it's not just at home or just at school, it's pervasive. It's manifested by deficits in social emotional reciprocity, meaning if you could generalize that term and think of the child who's very perhaps one-sided, who's pretty stilted in their conversational structure and not that back and forth. When you're assessing for an autism diagnosis, you're specifically looking for that behavior. You're looking for the child to, in a formal evaluation, ask the examiner about him or herself, and they're responding to specific prompts that are given by the examiner during that evaluation. Children on the autism spectrum tend not to do that. They tend to, as I said, have a more one-sided type of conversation. It's also manifested by deficits in nonverbal communicative behaviors used for social actions, so gestures, pointing, using kind of hands, as I'm doing and as I do a lot, to make points. So children on the autism spectrum tend to have reduced behaviors in those areas. It's also deficits in developing, maintaining, or understanding social relationships. So difficult for those children to pick up on social cues, to understand maybe when a peer is kind of done with the conversation or has moved on, or they're not picking up on those social cues. Autism also has some restricted, repetitive patterns of behavior to meet the diagnosis. Restricted interests or activities is manifested by at least two of the following. So it could be stereotyped or repetitive motor movements, insistence on sameness, kind of inflexible adherence to routines or ritualized patterns of or verbal or nonverbal behavior, highly restricted fixated interests that are abnormal in their intensity or focus, so perhaps a strong attachment to something or preoccupation with unusual objects. Some of the most common unusual objects that young children might be attached to are things like exit signs, traffic lights, other kind of atypical things that children in that developmental period are often not have a fixated interest on. They could be hyper or hypo-reactive to sensory input. A child who is really sensitive to the tag in their shirt or really sensitive to food textures. That is another typical commonality among individuals with autism. Symptoms are present in that early developmental period. Symptoms can cause clinically significant impairment in social, occupational, or other important areas of functioning, and the disturbances aren't better explained by intellectual disability or an intellectual developmental disorder or a global developmental delay. The next neurodevelopmental disorder we'll run through some of the diagnostic criteria for is Tourette's disorder, it's called Tourette syndrome, but in other areas of the world, often it's called Tourette's, sometimes called Tourette's disorder. It's a heritable neurodevelopmental disorder. For the diagnostic criteria, you must have 2 or more motor tics that could be blinking or shrugging, and at least 1 vocal tic, humming, clearing throat, something like that. Tics have to be present for at least a 12-month period. The onset is prior to age 18. And the symptoms, again, are not due to a medication or other drugs or to another medical condition. And the last one I'll just quickly run through is attention deficit hyperactivity disorder, ADHD. That diagnostic criteria involves 6 or more symptoms of inattention for children up to 16 years, or 5 or more for individuals that are 17 years and older, and as well as adults. The symptoms of inattention have to be present for at least 6 months. They're inappropriate for that individual's developmental level. Hyperactivity and impulsivity symptoms, 6 or more of hyperactivity, impulsivity for children up to the age of 16, with 5 or more symptoms for adolescents age 17 years and up, and adults. The symptoms of hyperactivity and impulsivity have been present again for at least 6 months, to an extent that it's disruptive and inappropriate for the person's developmental level. Symptoms have to be present before the age of 12. It's present in 2 or more settings, and the symptoms have to provide some sort of functional impairment with school, work, or some kind of social functioning, or at least reduce the quality of that functioning. So since we're focusing on autism spectrum disorder at this time today, I wanted to give some brief statistics from the World Health Organization's most recent survey of prevalence of autism worldwide. And this was from November of 2019. Worldwide, there's diagnosed autism spectrum disorder as 1 of every 160 children. So that's about 0.6% worldwide. But some well-controlled studies have, however, reported those figures are substantially higher. The prevalence of ASD in many low and middle income countries is so far quite unknown. That's for a variety of reasons: lack of opportunity for evaluation, and other poor access to healthcare. It's 4 times more likely in boys than girls, and in the United States, ASD prevalence was 18.5 per 1,000. Percent. So 1 in 54 children aged 8 years at the age of 8. So that's 1 in 54 in the United States among the 8-year-old population. That was taken from the CDC in 2016. In the US, 44% of children who received an ASD diagnosis were evaluated by the age of 36 months, 3 years old. So more than half of kids are not getting evaluated until after their 3rd birthday. And minority groups tend to be diagnosed later and less often, which is a concern, knowing in all of the research that early intervention is best to help improve outcomes, particularly social outcomes for children on the autism spectrum, and those children therefore are then not able to take advantage of those services until well after their 3rd birthday. So autism affects all ethnic and socioeconomic groups. 31% of children with ASD do have an intellectual disability, so that would be a full-scale IQ of less than 70. 25% of individuals are in the borderline range for their full-scale IQ. That's an IQ of 71 to 85, so that's in that borderline to the lower limit of the low average range. And 44% have an IQ scores in the average to above average range, so going above 85, 90 and up. So this is just a graphic to show how much overlap there is with autism and other mental health disorders and with other neurodevelopmental disorders. So you can see, I already talked about autism spectrum disorder, Tourette's syndrome, and ADHD, and there is quite a significant amount of overlap in those symptoms. In addition, among children diagnosed with autism, 44% have been diagnosed with a specific phobia. So that's not necessarily a generalized anxiety disorder, that's a specific phobia to a particular items. That could be to needles, to the dark, to weather patterns. So 37% have been diagnosed with obsessive compulsive disorder. So when you're evaluating a child with autism, you have to keep that in mind, because a child who has very ritualized, routinized behaviors, those also present very much in an OCD presentation. So you have to be able to piece out which might be factoring into autism and which might be in the obsessive compulsive bucket, and often there's overlap between the two, which is why evaluations for autism are best practices, fairly lengthy with multiple data points. Unfortunately, for various reasons, for brevity, for difficulties of doctors having time available and reimbursed options from third-party payees. So it makes it difficult to do a 2 to 3 hour evaluation, to really spend quality time with parents and caregivers to get a good developmental history of the child, and also to be able to spend a lot of time observing the child. So oftentimes parents will come to us saying, I think my child might have autism. They got a quick evaluation from, perhaps it was a pediatrician, or perhaps it was just through one brief questionnaire. That's really not ideal. It misses a lot. Sometimes it can misdiagnose or provide a diagnosis when the diagnosis necessarily isn't there, and perhaps it's something else. So kind of an evaluation with multiple data points is really best practice. Other comorbidities with autism include 30% have ADHD as well, and 10% have a major depressive disorder, and 7% with oppositional defiant disorder. So quite a lot. So as you can see, that when you're dealing with an autism diagnosis, it's really not that simple. It's not that clear cut. And as clinicians, as I mentioned, taking into account the totality of the individual's strengths and weaknesses is very important. So when we consider the large proportion of children with autism who also have a disorder such as ADHD or obsessive compulsive disorder, we can imagine that these difficulties and symptoms are noticeable to peers. And previous studies have shown that children can recognize individual differences in their peers really by the age of 3. Compared to children with physical disabilities like blindness, children with neurodevelopmental disabilities encounter social scenarios such as teasing and rejection, and experience greater difficulty in maintaining friendships, which presents a significant risk for adverse physical and mental consequences such as stress, low self-esteem, depression, and anxiety. Social behaviors among children with autism can vary, with presentations including appearing withdrawn, to preferring to play alone, to approaching peers, but it may be in an unusual or atypical way. So children with autism may be difficult to comfort. So they may be the child in the classroom who has multiple crying episodes per day, may have a lot of difficulty with transitions. Parents will often call those tantrums or meltdowns, and sometimes teachers report that the child's always crying and always having difficulty kind of engaging in tasks and handling the transitions of art is now finished and now we're going to transition to lunch, having difficulty with those transitions. Kids on the autism spectrum also are more likely to use overly formal language and be very rule bound. They may be the child who raises their hand if another peer answered a question incorrectly and correct that child. So kind of missing that social cue and kind of what's accepted among children. So you could see how that could lead to rejection, that could lead to bullying, which I will talk about. So one core factor in determining how children perceive others is children kind of want to know, and they attribute a lot of a child's behaviors, a peer's behaviors, as to whether those behaviors are purposeful or not. So children in the early elementary ages often associate one's behaviors to be within their control. So that could be tics, that could be hyperactivity and the child who's having difficulty remaining seated, could be aloofness as a child with autism, or lack of empathy. So if another child fell on the playground and there's a child on the autism spectrum who may not necessarily notice or may feel more comfortable just walking away, may be perceived as rude, insensitive, lack of empathy. So children make inferences that behaviors are purposeful, even when a child is exhibiting symptoms from a disorder that is not physical in nature. So not a child in a wheelchair, not a child with blindness, which would be more physical in nature.
And children better understand physical differences. So if a child was, like I said, in a wheelchair or using a cane, than those that are neurodevelopmental in nature. And peer rejection in childhood, it predicts a wide range of externalizing problems in adolescence. And externalizing, I mean delinquency, conduct disorder, attention difficulties, substance use. Children who are accepted by their peers, however, tend to show much better school adjustment, have higher quality friendships, are friendlier, they're more cooperative, and they're more adept at initiating and maintaining social interactions compared with the terms in the literature, which I really dislike, are still lower status classmates. So I'm not going to use that term, but the term is just children who are different from them or perhaps neuroatypical. And among children with disabilities, they are bullied at a very high rate, particularly during middle school years. So in the United States, our middle school years are usually maybe 5th grade up until 8th grade. And the victimization rate for children with autism spectrum disorder in particular is substantially higher than the 10% rate for typically developing children. It becomes quite a vicious cycle. So not having friends makes a child with a neurodevelopmental disability like ASD or Tourette syndrome really vulnerable to bullying. And being a victim makes a child less likely to get friends. And then we have the beginnings of comorbid depression, social anxiety, and disorders like that. So the frequency of either being bullied overtly or rejected, so it doesn't have to be an overt bullying, it can just be a social rejection, which is very damaging to children, especially in that developmental period of those middle school years. That's highly associated with the load of psychological issues that can go on in this population. And so to improve peer relations for children with disabilities, it's really necessary to understand the context in which children make inferences or assumptions regarding the personal responsibility that a disabled child bears in regards to his or her challenges or his or her difficulties or his or her differences. So a child's cognitive level and understanding this context, as well as a child's exposure, how much contact do they have with the disability? How much do they know about it? Do they know someone with it? Is someone in their family struggling with something similar? Do they have a friend who has a neurodevelopmental disability? Whether that's through contact with a sibling or a friend or a parent, that's also a contributing factor in the attribution process. So in psychology, that's really known as attribution theory. And attribution theory, in essence, assigns some kind of causality and responsibility to someone's behavior. So it serves as our mind's perception of why people behave a certain way. And in children, this is really dependent on their cognitive level, the level of or amount of experience with or exposure to that disability. So for a child who may have a parent with a physical disability, they may be much more likely to approach a peer who has a physical disability compared to a child who has no exposure to it. So in looking at some interventions that were designed to improve peer attitudes toward a child with differences, the literature has predominantly identified factual information to be helpful in the positive attitude development toward peers with neurodevelopmental or physical differences. So really that translates into providing kids with facts about a peer's symptoms. So that could look like, the behaviors associated with autism are not something I can control. And giving kids facts have been positively associated with improving younger children, but not necessarily older children's perceptions. The other intervention that's been considered, and it's been used in anti-bullying interventions, is giving kids examples of ways they are similar to one another. So for example, something like Joseph likes going to the movies just like other kids in his class. Not necessarily giving them a fact about something, but giving them ways that they can see the sameness between them and someone else. So here we're putting kids on this even playing field and defining ways in which they're similar to bridge the gap in the manner in which they see themselves as different. And often, kids without neurodevelopmental disorders often see themselves as superior in social status than to a neuroatypical peer. So again, these interventions work better among younger, but not necessarily older kids. And the reason for that is because as children progress into middle school years, they become much more aware of the importance of social status, and they're less likely to engage with a peer who may be different from them, even though they may logically know that the child is not engaging in a specific behavior just to irritate others or for attention-seeking purposes. Now, what hasn't been considered, although many of the anti-bullying programs in the United States try to incorporate this into their curriculum, is the component of empathy in peer integration programs. And empathy is really different from sympathy. Empathy is the ability to understand and share the feelings of someone else. And emotion researchers generally define empathy as the ability to sense other people's emotions, coupled with the ability to imagine what someone else might be thinking or feeling. And it's really broken down, just perspective taking. And that concept is very difficult to teach to younger children because they haven't quite mastered that part of their brain development. So what needs to develop more fully to be able to provide good empathy strategies to kids is something called theory of mind. So I describe theory of mind as putting yourself in someone else's shoes. So again, it's not sympathy, it's understanding what someone else is thinking. So there's a classic theory of mind research study. It's actually we use it at NeurAbilities when we are getting one of our data points for an autism spectrum disorder diagnosis or autism spectrum referral. And it is called the theory of mind test. So you have a box and it has kind of a picture on the top of something that looks like red and white blocks. You give it to the child, you say, what do you think is in the box? They look at the box, they see the red and white blocks pictured on the top, and they are supposed to say blocks. You ask them to open the box, they open the box, and sure enough, there's red and white blocks in there. Then you bring another box very carefully because there's not blocks in it, but it's the identical box, looks exactly the same, has the same red and white block picture on the top. And now you ask the child, what do you think is in this box? They'll look at the box and ideally they'll say blocks. And then you ask them to open the box and they open the box and there's something else in it. For example, pencils. Other studies have put candy in it or something else, but we just put pencils in it. And then you close the box and you ask the child, now, if your mom or your dad or your friend were to come in this room, what do you think they would say is in this box? And a child on the autism spectrum might say pencils, not having that theory of mind that why would someone who didn't see any of this unfold ever think that a box with blocks on it would have pencils on it. So they have a much greater difficulty being able to understand what that other person is thinking if they were just to come into the room and not see any of this that had just happened. So the goal of empathy training programs is to enhance empathetic feelings, or really to improve the understanding of others, which does help increase prosocial behaviors. A greater baseline empathy often translates into more prosocial behavior. So prosocial meaning the child who may be more likely to notice that a child is sitting by him or herself at lunch and say, why don't you come sit with me? Or a really empathic kid might be able to go over to that child and sit with them. But it's really not just empathy that they need, because as older children progress, they now have the concern of what their social status is among their friends and among their peers. And now the thought is beginning to bud and develop in 6th grade or so of, if I go sit with this child who maybe that child is bullied, or maybe that child has a lot of tics from Tourette syndrome, for example, what are my peers going to think of me? So you could be a really empathic person, but you could get held back by the concern of what are my friends going to say? What are my peers going to say? We want to be able to get over that hurdle, but it's a big hurdle. So kids begin to show empathy around age 2, but their mastery of emotional and cognitive empathy takes experience. It takes a lot of practice, and this generally doesn't emerge until closer to age 7 or later, which is really 7th grade. And we know from research of Albert Bandura, that very prominent social psychologist, the importance of observing and modeling behaviors, attitudes, and emotion reactions of others. So the empathy really continues to develop as children's executive functioning skills matures and they become more capable of managing their own distress and gain that cognitive space they need to connect with another person's experience without feeling totally overwhelmed themselves. And that's really not until middle childhood that those advances are seen in children's developmental skills. And that's the time that we want to intervene. So we know that the key components that factor into a child's positive attitudes toward a peer include their ability to take perspective of one another and their capacity to imagine what others are thinking and feeling. Like I said, that really isn't until middle childhood. So we're talking like 4th, 5th, 6th grade that kids are really advancing in this area, in this core developmental skill. We also know that there's sex effects of peer preference, particularly in the elementary school years, and across cancer and obesity literature. It was found that when presented with vignettes about girls and boys with and without cancer, girls rated girls more favorably than boys, and boys rated boys more favorably than girls, regardless of whether cancer was present or absent in the vignettes. And we also found this in the obesity literature with girls, but not necessarily with boys. So there was a study I conducted in graduate school to improve peer acceptance and behavioral intentions. So that likelihood that a child would ask a peer to sit at his or her lunch table, and that this in turn would help inform disability awareness trainings across various settings, including academic settings. And that goal was to improve peer acceptance and behavioral intentions toward children with differences. And I really wanted to focus on this concept of empathy and how to build and how to improve it, and how much of a child's changed behavior, would they be more or less likely, or would it stay the same, if to engage a child who was different from them, if we could build that empathy in them toward that child. So just a little graphic I love. So head injury, arm injury, neck injury, and the 3 people with each individual item of those things. We know exactly how you feel. So understanding whether a specific type of information or the combined effects of information is most effective can really help schools and teachers promote better sensitivity training and simplify the informational process of helping children in their classrooms understand differences between them and a peer with disabilities. And I was particularly interested in Tourette syndrome because there really wasn't much literature in this specific realm that was seeking to understand what it is about Tourette syndrome that puts these kids at such risk for social rejection and negativity. And with autism, there is an enormous amount of social rejection and negativity as well. So I looked at which information was most successful in improving typically developing children's attitudes and behavioral intentions toward a child with Tourette syndrome. So created 3 videos. The first video was kind of this fact-based information. So facts like purely facts about Tourette syndrome. So the fact that it's inherited, the fact that it's not purposeful, etc. And then I created a video that was just an emotional awareness informational video. So it didn't really necessarily have any facts about Tourette syndrome, but it had information about a child, such like, Robbie feels very sad when kids don't pick him to be in their art group, something like that. So pulling all of those emotions out and not necessarily giving facts. And then there was a third video that kind of combined the two. And we used an actor in these to kind of keep all of the symptoms, and the actor was portraying symptoms of Tourette syndrome throughout each video, but with a different script for each one. So we targeted 7 schools. This was done in the Philadelphia suburbs with similar demographics in each school. There were 200 participants with little or no prior information about Tourette's, and we looked at 3rd and 6th graders. And what we found was that kids learned a lot of information from the video that gave them just factual information. So things like, I was born with Tourette's, I'm not doing these behaviors on purpose, I can't control them, you can't catch Tourette's like you can catch a cold. And kids who were provided the video of the child with just evoking empathy learned the least about Tourette syndrome. So you can see that in this graphic. Now we examined the beliefs about the child in the video, and if kids were provided appropriate knowledge about the child, and beliefs and attitudes are 2 different things. So I can believe that the child isn't doing these behaviors, these tics, for example, on purpose. And I can believe that he or she was born with Tourette's, but I can still have a negative attitude toward that child. And that gap is really, really hard to fill. And that's where kids need help. So the element of something called social desirability plays a huge role, particularly in the middle school years when kids are much more aware of how they're perceived by others. So that's when I was talking about, you could have a child with a lot of empathy who's willing to feel sadness for the child who perhaps might be sitting alone, but the strength of what their peers are going to think of them, that social desirability is incredibly strong. And this cartoon explains and kind of depicts some of that, what I'm talking about. So what I found in the research was that boys had better attitudes when shown the video of the male actor, and girls had better attitudes when they were shown the video of the female actor. So we see these sex effects at work. And kids who had empathy incorporated into their video, so if they got just the empathy video or the combined video, they were more likely to have improved attitudes toward the child with Tourette syndrome. And kids who were older, so the 6th graders that I looked at, had a much higher level of empathy for the child in the video than younger children. Going further, kids who had greater increases in empathy were much more likely to interact socially with the child with Tourette syndrome. So really boosting that empathy response did translate into their intent to engage that child who was neuroatypical. And as I said before, the older children had higher levels of empathy, which isn't terribly surprising given what we know about the developmental trajectory of theory of mind. So I just wanted to share a graphic that's pretty powerful of where empathy resides in our brains. And if you look at the left side, that orangey yellow portions detail where we feel and process pain. And on the right side, the same portions of that area, that's the anterior cingulate cortex, are activated. So just to kind of recap, compared to previous research, this study used the novel element of first-person perspective. A lot of research studies have used videos, but they have a narrator, and they just have a child depicting behaviors of autism, but it's with a narrator over voiceover. It's not the child using his or her own thoughts and experiences. So this was a novel portion of the research. Children had an increase in knowledge overall, and the empathy video group had the least changes in knowledge. Older children had much more empathy than younger children, and there was a clear relationship between higher knowledge about a disorder and more positive beliefs. So empathy was a really novel element in this study, and it accounted for a considerable portion of participants' positive beliefs, attitudes, and willingness to engage socially with a peer with Tourette syndrome. So how can we increase empathy? If that's the goal, how do we do it? So first off, I feel we need to stop using the term. We use it a lot in the United States. It's also used abroad, special needs. And in my opinion, special has become a euphemism for separate. And people may disagree with me, but I see kids with neurodevelopmental differences as a very diverse part of the population, with 15 to 20% of individuals worldwide having some kind of difference. And just like other forms of diversity, the presence of those that are differently abled really does enrich our humanity in so many ways. And it's nothing to be ashamed or scared of, and our children's needs are not necessarily special. They all need to access the same things in life. It's just how they access them that might be different. But the needs themselves are not special, and we all have a right to access those needs. And if words matter, there have actually been very recent studies out of the University of Wisconsin and the University of Kansas in the United States on the particular term special needs. And it was found in 2016 that it is an ineffective euphemism. It's really not effective. And when kids don't meet that narrow definition of what normal is, they continue to be marginalized. We need to improve emotional literacy. So that's really built by schools, families. It's a multi-pronged approach built by the community to build children's ability to relate to one another and help children develop socio-emotional competencies as associated with greater well-being and better school performance and adjustment. So these are a couple quotes from, these are high schoolers and into early adults who have described what it feels like to have autism. And I love some of these, and I'll just read one or two. So the first one is, I feel like I'm in a play and everyone else has the script but me. They just seem to know how to do things, make friends, get ahead in jobs, and deal with difficult people. I love that one. The last one is another great one. It's as if everybody is playing some complicated game and I'm the only one who hasn't been told the rules. So these are really well-developed, well verbally expressed quotes of what it feels like to have autism. A couple others just describing, how they can be really rigid and fixate on things, sometimes as a distraction for not being able to fit in with other people. So in addition to a couple of things with how we can increase empathy, start with really good examples at home. In addition to asking your child how they did on an exam, you might ask, were you kind to other children in your class today? Pay attention to how you talk about other people, especially people that are different from you. Teaching empathy is often done in the home, and it requires that you as the parent or caregiver model empathy for others. Model that you prioritize caring. Be your child's emotion coach. So learning to identify and manage your own emotions is the first step to understanding others. Encourage compassionate perspective taking. So children and youth pay attention to what you say. So something like, how do you think Amir would feel if he got a text like that? If you're aware of some kind of negative text exchange between your child and someone else. Model this awareness in your own language as well. So something like, your grandmother might be feeling sad today because perhaps there was just a recent loss or death in the family because grandfather is no longer with us. I'm going to call her now to see how she's doing and if there's anything I can say or do to help. I also like to expand children's circle of concern. I call it the circle of concern. I don't think I coined that term though. I'm sure I read it, so I can't take credit for it. But many children are more likely to practice empathizing with close friends or family. Use newspapers, the TV, community events to broaden your child's circle of caring and find compassion for other people's experiences as well. They don't necessarily have to know them. There's plenty going on in the world now that we can certainly use news information and things in the media to be able to build some compassion toward others. Encourage your child to listen carefully, to allow to others, even if their perspective's different. It's fine if their perspective's different, but teach them how to listen carefully. Don't worry if your child or teen doesn't always respond with compassion either. It doesn't make them a bad person. It's a process and it's practice. Or if they're not willing to necessarily reflect with you on their feelings, they may say, not now, I'm busy. But empathy is not something that you pass or fail. And finding an empathic response can be especially challenging when young people are hurt or angry themselves, but just be really patient. Children and youth do practice and develop empathy over years of time. And lastly, stop, rest, and reflect. So this is really for the parents to prioritize time for reflection, being mindful about what we're saying, being mindful about how we're teaching children about empathy and compassion and caring. And then the reflect is just kind of a rest period where you're able to kind of reflect back, maybe at a later time. And teachers are really the first line defense during the day. Our kids are with teachers and educators many hours of a day. And they have an enormous role in this beyond just educating our children. So teachers are really have done a fantastic job and continue to do so. Teachers can model empathy even more than they already are. When frustrated with students, which happens all the time, let them see you pause and take a deep breath to try to see the situation from their perspective before you respond. If a student's upset, reflect back on his or her feelings. So saying something like, what I'm hearing you say is that you're angry. I can understand that. Let's talk about how we can address this problem together. Be aware of a student's nonverbal cues. So for example, if a student is slumping in his or her seat or appearing angry, arms folded, say something like, I noticed you're more quiet today than usual. Is something bothering you? Saying this instead of sit up in your chair and pay attention, that's really seen as reprimanding. So that can often go a long way in the child's day. Ask for the student's input when it's appropriate and when it's feasible. So for example, when establishing classroom rules or generating ideas for group projects, you can find opportunities to include your classroom's feedback when it's possible and when it's appropriate and relevant. Give examples on how to act on empathy, such as helping, showing kindness, or just simply listening, and practice it. So create opportunities to practice taking another's perspective and imagining what other people are thinking, doing role plays, reading and discussing books that are designed to teach and build empathy toward children in very specific situations, and using a what would you do type of approach or vignette. That's really very helpful. So there's a series of books published for specific areas of differences that can be used in the classroom to help increase awareness, and I'll show you some of them. But I'd also like to, just note that, setting really clear ethical expectations. So expect students in the classroom, setting a rule book, setting up and placing it visually prominently in the classroom of what is expected to help students care about one another, establishing guidelines for unacceptable language and behaviors with clear consequences delineated so that kids know that if I do this, then this is my consequence. And as I said, enlisting students in establishing some of the classroom rules, getting their feedback, getting their buy-in. So educating the school community about neurodevelopmental disorders, just for example, autism and Tourette's, to name a few. School trainings is very critical. There was a recent study of about 70 school-based speech language pathologists, and what they found was 85% viewed bullying of children with autism as serious or somewhat of a problem. All agreed they should intervene in acts of bullying, but not all felt comfortable to do so. They provided responses such as, I think it's the teacher's role, the principal's role, not necessarily my role. Giving everybody in the school kind of authority and some autonomy to be able to intervene when they see bullying going on. And 78% were in a district with an anti-bullying campaign, but a much smaller percentage were in a district where that campaign focused on children who were uniquely at risk. A couple of other things of how to improve the school climate: increasing supervision in high-risk areas, the bus line at pickup, in the lunchroom where there's lots of kids and much fewer adults in that ratio. Ongoing teacher discussions about what they're hearing, what they're seeing in the classroom, in the hallways. Evaluate anti-bullying programs to really see if they're working. Often there's anti-bullying programs placed, but there's no further follow-up of whether or not they're working. And there are, on the positive note, there are many studies showing that bullying may be decreasing over time. So these policy and cultural shifts are certainly making a difference. Contact the teacher if you notice something going on, or if your child's telling you even about another child. It's okay to just point that out to the teacher, make him or her aware. And then if necessary, if it's your child and you feel like things aren't getting done, you can certainly go up the line to the principal, the superintendent. In the United States, we have the school board, so kind of what the highest entity is in your area. And really being well-versed in knowing the state laws and policies for your state or your province. These are a couple of resources. These are some great books that are written in language that is developmentally appropriate, typically for the elementary school age, some specific for autism, some for ADHD, etc. So these are some great resources you can get online. In the United States, there's a number of resources for parents and caregivers to follow. We in the United States have something called the IEP process, the Individualized Education Plan process. That is to identify kids who have learning disabilities, autism, medical disorders where they need special academic accommodations to be able to fully function in the academic setting and get maximum education from their program. So, there's a link there to the guide if you find that your child has already been identified, but the IEP process isn't necessarily working in your district and what your rights are within that. And if you'd like to contact us, here's some ways to reach us at NeurAbilities. Facebook, Instagram, LinkedIn, etc. You can also join our mailing list and find out about future webinars and other events. And now I would like to open this up to questions.
Thank you, Dr. Azlen Theobald. That was really informative. Appreciate that. We do have a couple of questions. The first one is, what word would you use to refer to children with special needs? You talked about maybe changing that terminology.
Yeah, I think that's tough, and things have changed quite a bit in the climate of change that we're in right now. You know, it's gonna, I think, continue to change. So I even the word disability is something that you know, we're trying to, you know, take that term out. I'm sorry, I'm trying to keep that term, but, you know, older terms such as, you know, handicapped, differently abled kind of came into the nomenclature a little while ago, and that's kind of leaving the lexicon. Special needs, as I talked about, that's not necessarily from the literature best practice, but I think some respectful disability languages, I typically call it like developmental differences, because that doesn't necessarily, it's not necessarily a negative connotation, but you know, it's accurate, and there are people who are typically developing who you know, have other difficulties where that term would still be applicable, and you can even just, you know, ask the person what they prefer. You can open that conversation up to them. For an older child, adolescent, teen, early adult, you can certainly talk to them about it. So I think those the kind of neurodevelopmental differences is something that, you know, I typically use.
Okay, thank you. Also, can you talk a little bit about social skills classes and therapies, and how that may benefit or address empathy training?
Yeah, sure. So there's a number of tools in social skills training. Often, you know, the first thing that I think of and that I've used with a lot of good efficacy is the talking stick process for kids on the autism spectrum. So a lot of kids on the autism spectrum either don't want to engage in conversational skills, or it can be extremely one-sided and no pause to ask the other person, what do you think? Or did you ever play that game? Or have you ever been to London? So, you know, using the talking stick and kind of practicing with a small group of kids, each one is holding it. So there's kind of this expectation, and the talking stick protocol doesn't have to be a set period of time where each kid has to talk for even a minute. They can talk for 10 seconds to limit that kind of anxiety that they feel. But it's time that they can say something and take their turn and then pass it to someone else. So it kind of practices very slowly that it's other people taking turns. And then from that, you can build on the reciprocal nature of conversation. There's a lot of board games that can help teach turn taking. They're visual, they're kind of more engaging. There's a lot more manipulative. So that eye contact of having to talk to someone can be really difficult for a child on the spectrum. But adding in other buffers like, you know, Monopoly or other board games are helpful to kind of practice that turn taking. And you're doing something social, but you're sort of kind of still doing it independently. But nonetheless, it's still a social process. And have, you know, visuals that it's your turn, like dice or counters or a timer or something like that. Using another strategy is using pictures of people and have like blank thought bubbles, like in a cartoon, like blank speech bubbles. And the child needs to use their observation skills of what's going on in that setting to fill in kind of what that person is thinking. And that's a great way to practice what that person may be thinking emotionally based on their facial expression, their affect of what's drawn on their face, establish what the context is of the situation, and work out what the two people in the situation in the vignette might be saying or thinking. Yep.
And we're even seeing some virtual social skills classes now.
Yeah, we are, absolutely.
I don't have any further questions.
Okay.
So
We are right at the hour, I think.
yeah, I think we are.
Great. There's
Go ahead.
some of the books that I showed, they are helpful. Just a caution that a lot of books that are out there are written by parents, so not necessarily coming at the content of the book from a clinical lens. So really more those books that are written by parents. They're great, and I think they're wonderful ways of kind of helping express. But some of the ones that I posted are more written from a more clinical lens, but certainly with the keeping in mind that this is developmentally appropriate language for kids to be able to explain it. So those are often better used in the classroom as opposed to some of the more parent written books.
Azlen, I've had a few other questions come in here. Can you give any advice on putting your child with autism in a preschool and how to go about that? How much to tell the teachers and how much to expect from teachers?
I think it's a very individual decision based on the parent, what the child's behaviors are. I think when you're looking at preschools, some of the preschools here are private preschools where they're paid. In other states, public school districts will offer a publicly state-funded preschool setting. So I think there's going to be a bit of a discrepancy as if you're paying for your child to attend a private preschool versus if they're going to be in the more public school system. But if you have any question of a diagnosis or the behaviors your child is exhibiting, certainly get them evaluated. Certainly have data from a medical provider about what is going on with your child. That report will often have really good recommendations for not only what kind of academic setting, but what kind of accommodations they can qualify for and what should be implemented. And some of the more private-based preschools, because they're not publicly funded, may not be able to handle a child who's very severe on the autism spectrum or severe, and even in a very severe ADHD case, they may not be able to manage those behaviors. But you can certainly meet with the school district, and you can set up something. In the United States, we call it a child study team meeting. You can certainly ask to have a meeting with the educators and the staff at that school to explain what your child is experiencing, how they cope best. Maybe the child doesn't do well in transitions, or maybe they need extra time before the transition is going to occur to have kind of like a countdown or an extra couple of warnings to be able to manage their behaviors a bit better. So I think communication is really key, but also having a formal evaluation is also really helpful, because you'll have some of these clinical recommendations of what is going to be best for your child and how your child will best thrive.
And what can parents do to educate themselves? There are so many therapies that are suggested, and where do I start with knowing what to do?
I'm assuming this is specific for a child with autism. So the kind of gold standard treatment for autism is, and especially the younger the better, is applied behavior analysis therapy. We offer that at NeurAbilities, and the goal is to kind of shape behavior toward the positive things that you would want to see to help extinguish negative behavior. So it's not punishment based, there is, but it's kind of guiding and shaping behavior toward what you'd like to see. So praise for the child who may have, walked up to another child at the playground or try to even parallel play. Lots of praise for that, because that's something that you want them to try to feel comfortable with, and to kind of bridge that social connection that's lacking among the autism population. But there's many social skills therapies out there that lots of books that parents can look at, and I could put together a list for some of the more parent-based books that would be helpful for parents and caregivers that they can access pretty readily.
And we also had a request for the video that you created on Tourette's.
Oh, yeah, it's 3 videos. I can I can certainly figure that out. They're copyrighted, so if they're going to be used anywhere, it's just just being aware that they're copyrighted. But and you can certainly reach out to NeurAbilities if you want to use them in any kind of formal setting or in a school setting, and I can share with you how to do that.
Okay. And then I think one final question. Well, we did have a question about genetics and autism, and this is a great opportunity to share that next Wednesday, July 1st, Dr. Richard Bowles will be presenting on the benefits of genetic testing for treating autism. And he is the director of our neurogenomics program at NeurAbilities. So he'll be able to answer all those questions on the genetic basis of autism. And then just before we part, one final question. A family who has twins, and it sounds like one has autism and one doesn't. And how do we teach the one who may not have to have more empathy and understanding of the other's differences, and deal with the perceptions that go along with having a child with autism?
Yeah, and that is a really vulnerable population too, the siblings of individuals with neurodevelopmental disorders or physical disabilities or cancer. That is a population that there has been quite a bit of research in that area. And I think that is a really vulnerable population that's often overlooked. Parents are often pulled in a much higher percentage of their time and energy and mental capacity and physical capacity has to go toward the child who has this neurodevelopmental differences versus the sibling who may not. So I think it's really important to, there are a lot of books out that are, not a lot, some books that are out available for kind of continuing to support the rest of the children who are more typically developing. But I think it's really important to carve out something called special time, individualized time, one-on-one time with that sibling. Doesn't have to be hours and hours a day. It can be just before bed. It can be 15 minutes of really quality time with no phones, no screens, no distractions, where that child is the focus. And it's something that the child can look forward to, feel that they're still a really important part of the family. Trying not to use that sibling, just sometimes it just happens, and it's not a wrong thing to do, but trying not to make that sibling, especially if they're close in age and especially if they're in the same school, to kind of be the overseer for the other child. Make sure your brother or your sister got here or there okay, make sure this. So trying not to too early parentify them and make them kind of responsible for that other sibling in the school. Let the teachers and the educators and the staff manage that, but also kind of allowing opportunities to build empathy with that other sibling too. Help them. There's going to be times when they're going to feel angry and frustrated and withdrawn and lonely because what about me? So really trying to kind of keep that in mind and praising them when they're able to tolerate things, like if the other child had a bad meltdown, that when the sibling kind of handled it well and didn't have his or her own outburst, praising the child for that, like letting them know that you noticed it, really catch them being good, catch them, catch them managing.
Okay, Dr. Azlen Theobald, on improving social outcomes for children with autism. Thank you so much for your time this morning. Thank you to all the participants for tuning in to the Autism Specialty Care Education Series brought to you by India Autism Center and NeurAbilities Healthcare. If you would like an e-certificate or would like to leave feedback for us, please fill out the Google form attached and we will send your certificates within 4 working days. Please note that the form link is only valid for 24 hours, so please make sure you fill it out within that given time. In case you are unable to fill out the form, please reach out to us through the WhatsApp on the number given on the slide or email us at info@indiaautismcenter.org. If you would like to stay updated with the other webinars, please follow our social media handles or the link in the chat box. In the recording of this webinar will be available on both organizations' YouTube pages within 1 month from the date of the webinar. And we look forward to your suggestions and hope to see you next week for the benefits of genetic testing and treating autism by Dr. Richard Bowles. That one will be at 10 o'clock Eastern Daylight Time in the United States and 7:30 p.m. in India. It will stay back now for a few minutes to answer any further questions you may have, and you can use the chat box to ask them. Thank you all so much for coming.